Hey guys, we're going to talk about oncology and OT's role specifically in oncology. And my husband has just decided to weed eat, so that's fun. Hopefully you can hear me, but if not, we'll try again later. Okay, so we're going to proceed. This is coming from chapter 45 in your text, and then some additional resources as well, because your text has good information, but I didn't feel like it was super inclusive. So check the additional resource that I'll post in Canvas, and then from your slides too, okay? Always ask me if you have more questions, but jumping in. Talking about cancer, we know that cancer is the leading cause of death worldwide. You guys see that up there. Everybody's been affected by it. We all have a family member, loved one that's either going through it now, has been, or sadly will go through it, right? And then, so that's just personally. But then we're going to help these folks on down the road. And maybe it's not just our patient. Maybe it'll be our patient's family member or a child or something like that. Okay, so it's just got such a wide-reaching, condition, and so we really want to be familiar with it. The most common types of cancer, maybe not the most common because it varies by men and women, but some of the most common types, so would be prostate cancer, lung cancer, melanoma. People don't realize how serious melanoma is, but it is. And then just remember and keep in mind that the cancer is named for the site that it originates, okay? So we'll talk about in the next slide about METs and how the cancer is named. So here we see that METs METs the spread of cancer from the originating site to then a different location, to a different organ or multiple organs. Okay, so when you hear people talk about multiple METs, that means that maybe it started as lung cancer and now they have METs to the brain or whichever different system. Okay, so not good when we hear that. All right, moving on to the stages of cancer. This is something that you're going to want to be aware of. I know that we cover a lot of different stages with the different conditions, but especially with cancer, just realize that one is the kind of the milder, and then it progresses on down to 4, which is the real severe. Okay, so in stage 1 there, they'll have a tumor present, obviously, but no spread of the cancer, so that's great. It means it's operable, usually fully operable. There would be no METs, no spread to the lymph nodes, and prognosis is good. So you see there 70 to 90% survival rate after 5 years. And so when we talk about prognosis, they're going to refer to that as the survival rate after 5 years. Okay. And that would also come in terms of remission, is if you've not had a substantial change within that 5 years, they're going to say that you're in remission. Okay. So then stage 2 of cancer would be localized spread of the tumor. It would be operable, limited spread though, so it's still going to respond to the treatments like our chemotherapy or radiation, and so it would be responding to treatment. Okay, 45 to 55% survival rate there after 5 years. Moving on to stages 3 and 4. Okay, so stage 3 is that the primary tumor has spread to multiple organs. Does surgery, so they're going to go in and do surgery. You might just be riding around on the lawnmower at this point. I'm not sure. No, he's just parking in the basement, so I think we're still okay. Hashtag being married 10 years. Love him so much. Okay, so the primary tumor has spread to multiple organs. They're going to do surgery to try to remove the tumor. However, they're going to get the majority out, but it still may leave some cells behind, some residual cells behind, okay? At this point, the lymphatics may be affected, so we're getting more severe, right? You're looking at a 15 to 25% survival after 5 years, okay? More detrimental. Then stage 4, not great. Inoperable primary lesion. So, this is where you're going to start getting your terminal diagnosis. Dependent on the cell's response to treatment. So a lot of times they might still do chemo, radiation, but the cells may or may not be responding to those treatments. And this is when you're going to have your multiple METs. They may be I mean, you can just have mets in about any organ in any body system that you have. So it's pretty hard. Okay. And so less than 5% survival there. And when you guys are thinking about these stages of cancer, think about obviously how your treatments are going to change based on where your patient is in these stages. And this is something that you would get in your chart review. It's going to tell you what stage of cancer, if they do have mets, and you're going to start thinking about what your treatments are going to look like. Also for the for testing purposes, right, for the MBCOT, they're going to want you to recognize that somebody that has maybe breast cancer of a lower stage and it's responding successfully to treatment, that's going to be, you're going to have some rehab goals for that kind of client versus somebody who's in stage 3 or 4, maybe looking at quite different goals. Maybe we've been looking at palliative or hospice care that we'll talk about soon. Okay. But it's important to know the stages of cancer for that reason. Moving on to the treatment options. So surgery, they are going to remove the cells. And that's pretty much what you think, where they would go and take out the tumor. It may look like reconstructive surgery. For example, like for breast cancer, they may do reconstruction, or maybe it's a limb amputation if that need be. Then radiation. So for radiation, the goal there is to kill the cancer cells and to shrink the tumors via the radiation drug, okay? That was a misstatement. I'm sorry, not radiation drug, but just the radiation treatment itself, right? So then chemo, and this is where they are using those specialized drugs to target the cancer cells and to try to kill those cancer cells, okay? Immunotherapy is where they're trying to strengthen the immune system to fight the cancer. And then the stem cell transplants is trying to restore what is killed by the chemo or radiation. And then your hormone therapy, we're going to talk about that a little bit later, but also trying to use your body's own hormones to try to affect that cancer. Okay. All right, so then going off of those, we'll talk about some complications and some things you need to be aware of if your client is having these sorts of treatments, okay? So when we go in, we may be working directly with that cancer diagnosis, but it may also be a secondary diagnosis or something that they've had in the past that still may be affecting them, okay? So it's important to think about this in a lot of different realms, but some things to be aware of. So if we were treating this client who has had surgery, what would our role be, right? So maybe it's positioning post-op in the room. So right there, as soon as they come out of surgery, how are we going to position them best? It's going to depend on what kind of surgery they've had, obviously, but maybe we need to manage that edema and the lymphedema that could come with their surgery. Maybe we need to position them in a way that's going to prevent the risk of developing a contracture or a scar formation, those kinds of things. Early movement post-operatively it is a recommendation for most surgeries now. This is going to go big time by what your surgeon recommends. Okay, so if they say hold, then we're gonna follow the surgeon's orders always. But it's tending towards early movement post-op. Okay, and then patient education for prevention of complications, and that could look like letting them know what to expect down the road. Okay, and how to prevent these things that they don't even know are a possibility with the complications with the surgery. So the lymphedema or the development of contractures or the scar management, things like that. Okay, picking back up. So chemo. Things to think about with chemo, some specific side effects, maybe cancer-related fatigue, and that one's not just with chemo, okay? It is common with chemo, but maybe with any of the treatments, really. So cancer-related fatigue means that they are fatigued beyond what you would expect of a normal level. So maybe they've just done a little bit of housework or just worked a little bit, but they are fatigued to the max, and you wouldn't expect that generally, but we know that it's from the cancer. Okay. With chemo, you would look for excessive bleeding. And that's because the chemo and those drugs are affecting their lab values and their blood counts and all those things, right? So we're going to be looking out for their platelets and their different levels that may cause excessive bleeding during that time. Okay. Acute neuropathy. This is specific. I've seen this in a lot of my clients. You guys will too. And it's something that we specifically with OT are pretty good at treating, right? Because we've talked about other clients with neuropathy, specifically like diabetes. But chemo-specific acute neuropathy. So before they started having these treatments, they were fine, had complete, their sensation was completely intact. They were able to do completely normal things. But since having this treatment, it has dulled their sensation, okay, and caused them to have peripheral neuropathy. Treated similarly to the other diagnoses that we've talked about, only know that the cause of this is probably not from diabetes. It's from the chemo drug, okay? And so with that acute neuropathy, think about sensation and think about specifically they may have trouble now with using utensils to feed themselves. They may have trouble with fine motor coordination and fine motor control if they're used to being able to button small things, and now they suddenly feel fumble-fingered. It's frustrating. Loss of protective sensation. So they're used to being able to feel. They're not used to having to compensate with their vision to do things. But those are the things that we would teach them, right? And then also moving on from there, the next one says cancer-related cognitive impairment. And this is something that is very common. So 75% of the clients that have had cancer would develop a cognitive impairment of some sort. So that is something to really be aware of. Let them know that it's common. It's to be expected. It can be different levels. It doesn't mean that they're going to, just lose it altogether, but that it is a side effect of that nasty cancer. And it's something to make the family members aware of as well, because they may start to notice it too. And just to reaffirm that and say, yes, that is one of the side effects. Okay. And then pain. A lot of cancer patients have pain. Some do not. And if they don't, that is a true blessing. But a lot do. And so we also know some ways to help manage pain, in addition to medicines and things, but also guided imagery, breathing, different positionings, and different things like that. So know that they can be in quite a bit of pain at times, and that's also a side effect of the cancer, right? Okay, moving on to radiation. And I've dealt with this one with a client of mine. She I don't remember where her specific tumor was, but she had had radiation done. It was somewhere over here. It was in her upper chest, shoulder area. And she had had radiation done, and the radiation, she had suffered a burn. So you're going to see there, it says radiation burns to the skin and soft tissues. Hers was a very severe burn to the skin. So at this point, do you guys remember from our burns that we had to position, in that anti-contracture position, the kind of the crucifixion pose, right? And so we had to really stretch and work on this scar that she had, as well as, managing her other issues. So there were a lot of things that you couldn't do. That's not a real area that you can, there are certain things we would try to, massage, but then you'll see the next one, skincare and pH management is critical here. So you can't use a lot of certain lotions or cleansers and things like that, because that can affect the pH of the skin. And so that was a very unfortunate situation. We really had to do a lot of compensatory strategies, dressing strategies in that situation, because it really affected her like, kind of like a CVA might, like with a hemiplegic kind of situation. And so I taught those compensatory strategies. We had to get, we had to do some education as far as her bowel care and being able to reach behind her for toileting, and so some different things. So it's just all going to depend on where that client's deficit is as to what your treatment approach is going to be. Okay. All right, then immunotherapy, making sure that that client is on a great medication management